Good day. This is Dr. Andrea Grzeski from Doctor's Data Laboratory. Today we'll be discussing the assessment of the effects and the detoxification of endocrine disruptors. We'll review laboratory assessments for exposures, detoxification, and nutritional status. And we'll look at detoxification strategies and nutritional supports that may reduce the bioaccumulation of endocrine disruptors. An endocrine disrupting substance is a compound, either natural or synthetic, which through environmental or inappropriate developmental exposure alters the hormonal and homeostatic systems which enable an organism to communicate with and respond to its environment. Toxic metals and chemical exposures may occur through contaminated food or water, through breathing contaminated air, through contacting contaminated soil. Chemical exposures can occur through the use of cleansers, solvents, cosmetics, or plastics, and toxic and metal and chemical exposures may also bioaccumulate up the food chain. Metals, as well as chemicals and plastics, may have endocrine disrupting effects. In addition to hormonal and reproductive effects, toxic metals and chemical exposures may induce epigenetic changes throughout the organism's lifetime and can contribute to chronic inflammatory diseases. They can alter enzyme functions important for hormone metabolism and detoxification, and cumulative exposures may exhaust antioxidant reserves in susceptible individuals. The lack of antioxidants eventually overwhelms detoxification pathways, and this can result in hormone disruption because detox pathways must process hormones, neurotransmitters, endocrine disruptors, and other antibiotics. Chemical as well as metal elements may interfere with thyroid function. Perchlorate is a naturally occurring and man-made chemical that can affect the function of the thyroid gland at high doses. Perchlorate is present in some public drinking water systems and some foods, primarily animal products, grains, and processed foods. A recent study found that lower iodine levels in breast milk were associated with perchlorate levels. An increase in plasma bromine levels may increase plasma TSH, thyroid-stimulating hormone, with an inhibitory effect on thyroid activity. In one study, the percentage of patients with a high TSH but normal free T4 value was significantly higher in the group with the higher bromine values. The main routes of exposure in humans stem from bromide residues present in food due to the abundant use of bromide-containing pesticides and food additives. The negative ion of the element fluorine easily displaces iodine in the body because it's much lighter and therefore much more reactive. Fluoride-thyroid iodine antagonism interferes with iodine uptake. TSH output from the pituitary gland is inhibited by fluoride, thus reducing thyroid output, and children exposed to high fluoride levels have altered thyroid profiles. Epidemiological studies involving workers have found associations between exposure to specific pesticides or industrial chemicals and levels of thyroid-stimulating hormone, testosterone, and prolactin in adults. Some of these studies have also found significant associations with other problems, including diminished sperm quality, impaired sexual function, and testicular cancer. Both male and female breast cancers have also been associated with occupational exposures to EDCs. Numerous studies have found associations between occupational exposure to solvents or pesticides and subfertility or adverse effects on offspring, such as hypospadias or cryptorchidism in male children. While pursuing appropriate testing for suspected chemical exposures, additional testing may be considered to further assess the patient's toxic metal exposures, oxidative stress levels, and detoxification status. Iodine is antagonized by these toxic halide exposures as discussed. Iodine is essential for normal thyroid function and is necessary for reproductive success. The measurement of urine iodine tells us whether or not the patient is excreting iodine as expected for the U.S. population. About 90% of an iodine dose is excreted within 24 hours. A pre-post challenge with an established dose of iodine allows for the estimation of the percent iodine saturation in the body, and this may be used to monitor the efficacy of iodine supplementation. Iodine status and metabolism are affected not only by iodine intake, which has decreased significantly over the years in the U.S. population, but also due to the intake and retention of goiterogenic halides, bromide and fluoride. Excessive intake of these iodine antagonist halides can accumulate in tissues, displace iodine, and compromise the production of thyroid hormones, the integrity of the thyroid and mammary glands, and may interfere with normal reproduction or hormone responses. While our clinical experience supports the concept that iodine will displace bromide, and we often see bromide displacement of 2 times the provocation with iodine, there is currently no way to estimate the size of a bromide bioaccumulation. Fluoride does not displace, and avoidance is the only known remedy for fluoride exposures. The return to optimal function includes the removal of metal toxicants, first from the immediate environment to prevent further exposure, and then from the body through the support of detoxification pathways. Exposure to toxic elements increases the amount of oxidative stress and may interfere with detoxification efforts. Urine porphyrins may elevate due to acute recent exposure to toxic elements or chemicals, or porphyrins may remain elevated due to the bioaccumulation of these toxins. Thallium and arsenic may clear the blood rapidly after a point-in-time exposure, so blood may not accurately express those exposures when we look for them. Hair is a good screen for recent toxic exposures, but may easily be contaminated by external sources. And screening for recent exposure in urine may reveal unexpected sources of exposure. An estimate of metals bioaccumulation may be obtained with a post-provocation or a post-challenge urine assessment. As stated, blood levels intended to measure true poisoning may look normal during chronic or subacute exposures, but those metals may still be bioaccumulating. Actual bioaccumulation or net retention may be assessed by provocation or challenge with the pharmaceutical agent, and then the measurement of urine toxic elements. These challenges show us post-provocation an estimate of the amount of metal in the patient's tissues. Metal detoxification after such a challenge may reduce bioaccumulation and decrease oxidative stress, and we'll also see the post-challenge levels go down as the therapy removes the metals from the patient. Metals also affect porphyrin synthesis, and the porphyrin pathway is assessed in urine to assess the enzyme function on the heme synthesis pathway. Heme is incorporated into hemoglobin, also into the cytochrome P450 enzymes in liver phase 1 detoxification, and certain enzymes on the methylation pathway. The porphyrin pathway may be disrupted by arsenic, mercury, lead, and certain chemicals. Liver phase 1 and phase 2 must work together to efficiently detoxify and excrete toxins. In this example, phase 1 is appropriately upregulated from recent exposures, but phase 2 is sluggish and unable to respond due either to inherited enzyme variations or low levels of cysteine, glutathione, or other toxic metal exposures. 6 months later, after removing the patient from the environment, phase 1 is responded to liver support and the removal from the environment, but phase 2 is still sluggish, which heightens our suspicion that these may be inherited difficulties. Additional evaluations may be considered at this time to determine the cause of the phase 2 insufficiency. Glutathione in erythrocytes is an indicator of extracellular glutathione status, the overall health of cells, and of the ability to endure toxic challenges. It is a reliable estimate for baseline evaluations and to monitor the effects of therapy. The oxidation of DNA occurs readily at guanosine bases in the DNA, so the measurement of 8-hydroxy-2-deoxyguanosine, or 8-OH-DG, in urine provides a quantitative assessment of ongoing oxidative damage or stress in the body. Oxidative damage to nucleic acids results in base modification, substitutions, and deletions. In short, it causes mutations. When 8-OH-DG levels are elevated, it's important to identify the sources of oxidative stress and ensure the availability of glutathione and other antioxidants. Mineral cofactors are required by the body's protective antioxidant enzymes, and deficiency may occur due to diet or gastrointestinal disorders. Elements within erythrocytes estimate intracellular nutrients in other body cells, and an accurate assessment of intracellular nutrient elements may then guide clinical decisions for nutrient supplementation. The methylation pathway is the primary source of donor methyl groups. The pathway converts homocysteine to cysteine and then to glutathione through transsulfuration. SAMe, the primary methyl donor, and cysteine, the rate-limiting glutathione precursor from the transsulfuration pathway, are synthesized through these pathways. Specific enzymes on the pathway have been associated with neural tube defects and male infertility. These effects may be exacerbated by toxic exposures, endocrine disruptors, or malnutrition. Defects in the methylation pathway may increase oxidative stress, while defects in the transsulfuration pathway may impair antioxidant responses. A variety of chemicals and metals may inhibit the enzymes of the pathway. Inhibition of the pathway ultimately impairs glutathione synthesis and antioxidant status. So we need a functional assessment of this methylation pathway because DNA can only tell us about potential. Poor recycling of methionine may inhibit the synthesis of SAMe and thereby inhibit both COMT, catechol O-methyltransferase, and phase 2 methylation of toxins and estrogens. The activity of three enzymes, methionine synthase, or MTR, methionine synthase reductase, or MTRR, and methylene tetrahydrofolate reductase, or MTHFR, are tightly linked and have been associated with neural tube defects and infertility. Deficient function of other enzymes may have cumulative effects on the methylation pathway, elevating homocysteine levels and inhibiting the remethylation of homocysteine to methionine. Poor function of S-adenosyl homocysteine hydrolase, or AHCY, may elevate levels of S-adenosyl homocysteine, further increasing cellular oxidative stress. And poor function of cystathionine beta synthase, or CBS, may inhibit the synthesis of cysteine, the essential precursor for glutathione. In addition to inherited variation in enzyme functions, specific nutrients support each enzyme on the pathway, and specific environmental conditions may further inhibit each enzyme. The presence of an inherited variation in an enzyme does not indicate functionality in the living body, as the phenotypic expression of an enzyme may be affected on many levels. The assessment of COMT function may be important when patients have both inherited variability and exposure to exogenous hormones or toxicants. There are currently few laboratory assessments of COMT function available, which makes the evaluation of neurotransmitter intermediaries a valuable tool to assess this enzyme and enzymes such as monoamine oxidase A and B. A healthy gut's capacity to methylate and detoxify xenobiotics and metals may rival the liver's. Up to 25% of the daily methylation transactions in the body may be performed by the gut microbiome. An assessment of digestion, inflammation, immunity, and bacterial diversity provides an opportunity for clinical interventions. High-fat diets may promote inflammation and decrease microbial diversity. Dietary phytochemicals, such as soluble fiber, sulforaphanes from broccoli sprouts, EGCG from green tea, or lignans from flaxseed may positively enhance interactions among metabolism, diet, the gut microbiome, and the epigenome. The composition of the microbiome may affect the body's response to environmental stressors. Diet and toxic exposures may play an important role in creating a microbiome that is conjugate tolerant or one that deconjugates estrogens and other xenobiotics. Stressors, including toxic exposures, may increase inflammation and allow bacterial lipopolysaccharides from the gut into circulation. Circulating lipopolysaccharides may then depress cytochrome P450 phase 1 enzyme functions and may also cause inflammation in the central nervous system, changing mood and behavior. Lactobacillus and other beneficial bacteria can sequester metals in their cell walls and are then excreted in the stool, providing another method of detoxification from toxic metals. And ideally, all expected and beneficial bacteria should be present at 3 to 4 plus to ensure a healthy microbiome. A detailed environmental history and exposure inventory, followed by patient education to assure future toxin or endocrine disruptor avoidance, is the first step back towards health. If available, and the specific exposure is known, toxicological testing according to the patient history may be pursued through specialty laboratories. The remediation of abnormal biochemistry, as indicated by laboratory assessments, may be required to fully restore health. And a combination of optimal diet and supplemental nutrients may help secure adequate nutrition and improve biochemical reserves and functions for detoxification. Sweating, with mineral repletion, either through exercise or sauna, may facilitate transdermal excretion of some metals and chemicals. And we may consider targeted therapies for any retained toxicants as determined by those laboratory investigations. Specific nutrient supports for liver detoxification phases may be considered based on the results of laboratory testing. Each phase requires specific nutrients. Poor phase 3 excretors may present with clinical indicators of bioaccumulation, but poor response to provocation for metals or other attempts to detoxify. Diet choices and supplements may improve glutathione levels and antioxidant status. Sulforaphane, improved intracellular glutathione ratios and reduced extracellular superoxide free radicals production in vitro in certain studies. Lithium has been shown to upregulate glutathione transferase, which participates in phase 2 detoxification. Gene expression of the rate-limiting step in glutathione synthesis may be increased by the use of curcumin and quercetin. Glutathione levels have also been shown to increase through the use of curcumin and quercetin in vitro as well as in vivo. One study in humans with autistic children did show that oral liposomal glutathione compared to a transdermal application provided an improved glutathione ratio in children using the oral version. However, this human study was not blinded or placebo-controlled, which is the gold standard in medical research, and further research is required. Targeted supplemental support of the methylation and transsulfuration cycle enzymes may also improve glutathione levels by providing more cysteine into the cellular environment. And supporting mitochondrial function may minimize free radical formation and oxidative stress, further improving patient detoxification. Dietary and supplemental antioxidants may also help reduce oxidative stress and improve patient detoxification, while lifestyle changes can further improve detoxification, minimize toxic exposures, and reduce oxidative stress. Many of the enzymes in the catechol estrogen pathway are modulated by components of diet. Estrogen addicts like 8-OHDG serve as a biomarker of oxidative stress and DNA damage. Increased adduct ratios have been associated with estrogen-related cancers. A study of 117 premenopausal women found an inverse association between dietary plant food intake and the ratio of estrogen addicts shown to reflect oxidative DNA damage and potential female cancer risk. Several classes of phytochemicals have been shown to influence the activity of phase 2 enzymes, including glucuronidation, glutathione enzyme activity, and sulfotransferase enzymes. And higher total dietary fiber intake, more than 25 grams a day, has been associated with significantly higher concentrations of beneficial 4-methoxyestrogens and lower concentrations of pro-carcinogenic biomarkers in certain human studies. A higher total fat intake, greater than 35% of total daily energy, was suggestive of a positive association with cancer risk biomarkers. So a variety of beneficial plant compounds may be obtained through a diet rich in vegetables and fruits. Anthocyanidins increase levels of detoxifying glutathione S-transferase and decrease the metabolism of estrogen to carcinogenic 4-hydroxyestrogen compounds. Still beans induce glucuronidation of phase 1 intermediary metabolites for phase 2 detoxification. Glucuronidation makes the detox metabolite substances water-soluble, which allows them to be excreted from the body. Sulforaphane is found in cruciferous vegetables with very high levels in 3 to 4-day-old broccoli sprouts. It's converted by an enzyme found in plants or found in some species of the gut microflora. Sulforaphane induces detoxification enzymes such as the glutathione S-transferases through NRF2 pathways. And the preparation of certain foods may determine their benefit or risk in the diet. High-temperature preparation of meats through grilling or smoking may produce heterocyclic amines and polycyclic aromatic hydrocarbons. The heterocyclic amines have estrogenic effects and are metabolized through the same pathway as estrogens, thereby competing for cytochrome, sulfotransferase, and glutathione enzymes. Both the amines and the hydrocarbons are considered carcinogenic precursors. Organic foods contain much lower levels of pesticides than conventionally grown produce, which may be fertilized by sewage sludge full of toxic metals. A wide range of organic and inorganic compounds may occur in animal feedstuffs, including pesticides, industrial pollutants, radionucleotides, and heavy metals such as arsenic. And finally, fruits and vegetables provide soluble fiber and act as natural prebiotics, thereby promoting detoxification and hormone metabolism. The promotion of Firmicutes and Bacteroidetes bacteria within the intestinal microbiome by dietary fibers has an important effect. These bacteria are able to metabolize dietary lignans into potent phytoestrogens. High blood levels of phytoestrogens have been shown to be inversely associated with the risk of breast cancer in epidemiologic studies. Correcting digestive complaints improves the diversity of the microbiome and ensures the assimilation of necessary nutrient cofactors. For those detoxification processes that are dependent upon the excretion of compounds in stool, the importance of eliminating constipation and ensuring regular bowel movements with fiber cannot be overstated. Probiotics improve intestinal microbial balance and participate in crosstalk and cellular signaling with the host immune system to modulate inflammatory responses and immune functions in the body. Probiotics may be a necessary first step in the restoration of the gut microbiome, but they are transient colonizers and do not restore full diversity to the gut microbiome. For that, we need to promote parasympathetic tone, and we need to make sure there are abundant natural plant fibers in the diet. Medicine and public health have traditionally favored a science-based precautionary approach aimed at preventing adverse health effects through education and practical exposure reduction whenever feasible. In the case of endocrine disruptors, such an approach will unfortunately require the medical community to step up and play a critical role in evaluating the science, educating the public, and recommending steps to government and to their patients to protect the next generation from the effects of endocrine disruptors and toxic metals. Thank you for your kind attention. For additional information on any of the tests reviewed in this presentation, please contact us at www.doctorsdata.com. Have a great day and a safe, toxin-free life.